My name's Shannon Knott. For those people that haven't met me before, I have the pleasure of chairing this session today, which is really looking at a range of telehealth initiatives across the country and looking at how we might be able to apply those into rural and remote context. Today we have three speakers who will be presenting each on respective projects that they've been doing in their own parts of the world, and then at the end of this, their presentations, we'll have an opportunity to ask them some questions. So if you have questions for any of our speakers today, if we can hold those up until the end, that would be great. Our first speaker is Mike Tran, a medical specialist liaison officer, Ken Tran, sorry. And Ken has an MBA with over 10 years of experience in the Australian healthcare sector. His role with Telemedic involves liaising with medical specialists to work out how they can provide telehealth systems to people across Australia. So please join with me in welcoming Ken.
Thanks, Shannon. Good morning, everyone. My name is Ken. I'm, as Shannon introduced so eloquently, I'm the Medical Specialist Liaison Officer with Telemedic. So my role exists because, as we all know, specialists are notoriously busy, and my role is to open that access up to the referring pool of GPs and practice staff that normally need to liaise with specialists. And the benefit of that is obviously to the patients in rural communities. Additionally, my other role is as a contributing author to this telemedicine neurology study. So very grateful of your very presence here in this room today. I know there's so many amazing topics concurrently done. So hopefully I can, this talk is very interesting and entertaining for all. The structure of how I wish to walk through this presentation is I'll include an 8-minute video, probably at the halfway mark, and obviously questions and answers towards the end. Just wanted to change things up rather than have me speak for the full 20 minutes there. And before I begin, I have to acknowledge it's the huge effort behind here with all the other authors, particularly Professor Yan. He's the supervising study. He's supervising professor for this study, and we also have 2 GPs within our authoring team. So it's been a privilege to work with what I see is the greatest minds within their respective fields. The key issue with this study here, and it's something we all are very familiar with, is inequitable access. Where you live really does matter. And for everyone in this room today in the Northern Territory, if we go by these numbers back in 2011, there really is less than 1.5 brain doctors available for neurological care today in this territory. So the numbers really speaks volumes on this, and we all know this. What that means is for neurological diseases such as Parkinson's, epilepsy, multiple sclerosis, these diseases are presented first up with the local family doctor. And it's very critical, obviously, to be able to have to be diagnosed and also treated in a very timely manner. And being in rural and remote areas of Australia, you're at a huge disadvantage, particularly as a patient. So there's really 2 quick solutions to this, or 2 obvious solutions. Model 1 is what I boxed up, and that really is just to train more brain doctors. And not only train them, but to somehow convince them to relocate and practice in rural areas. That in itself obviously have its own set of challenges there. The second one is the nub of our study, and that's to introduce and see what telemedicine can do to address these issues. And again, like Model 1, we have our own set of difficulties and challenges with this model, particularly GPs and doctors. Everyone, I guess, in this context, through no fault of their own, some are very unexposed to telemedicine and video conferencing, and so they have different views. And we also have on the other spectrum where they would embrace it as if because they're very technology savvy as well. The other main challenges, obviously, is from the patient's point of view. These patients are diagnosed with neurological conditions. The first thing that they really want is to be seen by a medical specialist in person, in the flesh. And that's a normal sort of expectation that they have. And it goes exactly the same way for their GPs. They present to their GPs. They want to see their GP in the flesh. Fortunately, we've not only been doing telehealth, we've been managing telehealth for quite some time, since 2012. So managing these expectations, enlisting doctors, speaking to doctors in a way that doctors and their support staff, as well as patients, we were able to recruit and enlist sufficient numbers for our study. So from the study perspective, we really looked at the qualitative aspects of telemedicine. And what we did was we compared the user experience of the patients that have received telemedicine and those who went through the traditional medical route. We also looked at some quantitative measures of telemedicine compared to normal consultations in terms of wait times. So our results so far, we're at 102 sample size, and for us this is important because this has reached a statistically significant number for us. Our aim over the next few weeks before we finalize our results and put it to publication is to just bump it up a little bit more, just to give that extra, extra significance there. I wanted to draw your attention to two findings. The first one is the qualitative insight that came out of this study. Dr. Langau, our statistician, in her brilliant wisdom, came up with a global dissatisfaction score, where out of a score of 14, the higher the score, the more dissatisfied the patient experience. And obviously, the lower the score, the more satisfied the patient experience. What we found was, if you look at the orange column on the top graph there, that represents the control group. They were more dissatisfied with their consultation than compared to the Telemedic, or at least the teleconsultation experience that they had. While we knew this would be the case, this was nice to see. The other part that I really wanted to draw your attention to was the quantitative results. And in particular, when we deployed telemedicine for this study, we thought that it was only useful for review consultations. What really came out of the data was that it was equally, if not more beneficial for the initial consultations. And in fact, the wait times for the groups of patients who had initial consultations with the neurologist was significantly less than those in the control group, for waiting times under 3 months. What I've got here is an 8-minute video, so it is a little lengthy, but it does show our journey through this process. But also it shows the user experiences from all the other perspectives, so the GPs, the support staff, and as well as the specialists, which I think gives a bit more of a bigger view of the study.
I just woke up that morning, and I had something twitching in my eye, and it didn't go away, and it got worse. So I thought, I'll just go and get a cloth and wet the cloth and wipe my eyes, and something must have got in it. But by the time I looked at myself in the mirror, my whole face had drooped on the right side. And then by the time I got to my husband and said there's something wrong, I couldn't lift my right arm, my right side had all drooped, and I couldn't use my right leg. My husband just said, "Oh my God, you're having a stroke." You don't get very much treatment for really important things, because I think we're expected to travel away anyway.
We have no neurologists here. For me to see the neurologist, we actually had to travel constantly to visit him.
Telemedic was formed to serve these communities. The purpose was, and still is, to deliver a simple and effective telehealth experience. While we expected healthy scepticism, the real lessons we learnt were from the unexpected, when it didn't always run like clockwork.
I was initially reluctant to embrace telehealth and telemedics as an extension of that, because I didn't feel that, I felt that to have an appropriate consultation you needed to be one-on-one in the room.
It was initially difficult to see how much benefit you would get from when there was a large component of physical examination involved, because obviously the specialist isn't in the room.
It was almost like we were pioneers in the idea of what telehealth was, and that historically there'd been some different views around what telehealth was and what it was providing the clinics and the specialists. So when I got involved, there was an uncertainty of what telehealth meant to communities.
When the Telemedic system came on board, that would have been in 2012, 2013. And I started using the system together with quite a few other specialists. And we found that it was a different way of approaching the whole problem of linking up the three parties, and that would be the patient, the primary referring doctor, and also the specialist.
It'll be the beginning of the virtual clinic as we have, and 5 minutes before something's happened at one of the actual rural clinics, and we're on the phone with them, trying to help them get going and facilitate, whilst the specialist is on the other side, ready to go. And we just learn how to juggle that relationship. And I think that the fact that we've been around for a while now, and we understand the nuances of that, makes us a really great partner to work with.
When I had my stroke, I'd heard about it before on TV and different things that were on TV that it was available. I never knew it was available in Mildura until my GP said to me, instead of keep running back and forwards to Melbourne, we can do a link.
When we actually did the appointments, I'd sit with my doctor, my GP, and he would log in.
Professor Yan was on the other side, and he said, "Hello, Sandra, how are you going?" And I said, "Good, thank you." And he said, "I just want you to do a few exercises, want you to show me how you're going."
My GP would be doing the physical tests for walking and things to check my gait. The cameras would be altered slightly so that the neurologist could actually look at me walking down the corridor.
A lot of the time when patients go and see their specialist, you get a letter back in a week or 2 weeks, whenever that may be, which gives you an idea of what that consultation, how it occurred, but it really only gives that specialist viewpoint of the consultation, whereas with telemedics, you're part of the consultation, so you're interacting with your patient and with the specialist at the other end. So when the consultation is over, you spend time with your patient, you can go over it all together. They have a further understanding because they can ask questions from me if they didn't quite pick up on things. So it really means that we're all on the same page.
The major advantage for the specialists is that they are able to have more frequent follow-up of their patients. And some of these patients are on very powerful drugs, and of course there's no drug without side effects. And these very powerful drugs that we have now for multiple sclerosis sometimes comes with side effects which need to be picked up really quickly. And So having the capacity to review patients frequently would allow for side effects to be picked up and for actions to be taken from there.
We were able to hook this gentleman up with a specialist team, I think down in Caulfield, which involved a specialist neurologist, a palliative care team, and a whole range of others. So there were about 3 or 4 different specialists all in the same room talking in Caulfield, talking to me and my patient in our room. And that was great. They introduced ideas that I didn't know about, the patient didn't know about, had previously had no access to. He was reaching a point in his life where travelling was going to be extraordinarily difficult. And we were able to, on the advice of what they gave us, we were actually able to implement most of those for the patient at home. It really was, one, an education, a revelation, and impacted the patient's quality of life actually dramatically. That, I think, was the light bulb moment for me.
Sometimes we've had calls where we've scheduled a 3-month review, and it's within those 3 months, and they call us to see if there's something that we could do to give them access to the specialist. And we can do that. We can give them that access, that they don't need to wait for 3 or 6 months to wait for their appointment or to wait till they have to go to emergency, that they can work with us to then get access to the specialist.
Since mid-2016, we have successfully completed more than 50 telehealth clinics. Our intention is to build on these telehealth services, developing new relationships with select partners.
It's instant. You know, you've got less stress catching planes and finding somewhere to stay and then trying to get around a hospital you don't even know. And whereas I just go to my GP and they turn the TV on and there he is.
My understanding of telehealth would be that it would be for follow-up. If the patient had been in Melbourne or Adelaide or wherever they had been, it would be for follow-up consultations. That was my initial understanding. But in fact, as time has gone on, we use it a lot for initial consultations, and it's really expanded greatly since I've been using it.
I know that we're ready and we're excited to partner with other teams out there and extend our experience into those spaces.
Telemedic has developed a scalable framework that can be leveraged to accelerate telehealth. We are actively seeking to partner with corporate, state and federal government programs.
So basically, to sum up, because I do realise there's a bit of a change of schedule there, and questions and answers we'll have right at the end here. The results of the patient study was, it confirmed a lot of things, and it showed a lot of insights that we perhaps didn't know about it, of value of introducing telemedicine into a neurology setting. But obviously from the video, there were a lot of other perspectives and additional value, particularly to GPs from the use of telemedicine. It introduces concepts of collaboration that never used to be there in the same way. And I think that really changes the dynamics between GPs practicing in rural, remote areas and specialists practicing, in the major cities there. Yeah, very keen to, if you're keen to find out how we can perhaps help your practice, we're very, text your name to this email or try and find me throughout this conference and we can have a chat. Thank you for your time.
Thanks, Ken. I think that was a great example of how technology can be utilised in some rural and remote parts of Australia to be able to link up specialist care. And I think particularly your patient stories are really strong ones. I think sometimes people who are a little bit apprehensive about initiating telehealth or integrating that within current workflows in a clinical sense sometimes forget about the benefit for patients and that realised benefit in terms of them and their own journeys from a sort of medical wellness perspective and looking at what other impacts there are beyond just a clinical presentation, the impacts in terms of travel, removal from family, that type of thing. Our next speaker is Justin Gladman. Justin, a colleague of mine, is a proud Wiradjuri man who is a GP registrar working with the Royal Flying Doctors Service based at Broken Hill. And Justin's been doing a lot of work around how RFDS can be able to outreach to some really remote parts of far western New South Wales by utilising telehealth. So please join with me in welcoming Justin.
Morning all. So I made the fatal mistake of giving my presentation to the admin girls at the office, and there's all these weird things that happen that I wasn't quite expecting. So I suppose when we think of RFDS, I think most people have the thought of us putting our jocks on the outside, grabbing a cape and jumping out of a plane, and that is partially true. But the services that we offer, I think, have certainly developed beyond that to include quite a strong primary healthcare facet to what we actually do. And more recently, we've employed 2 Aboriginal health workers to act as conduits between the services that are provided and the communities in which those services are particularly delivered. And as you can see from the list there, it's quite extensive what we actually offer. So the Telehealth project is under the auspice of the University of Queensland. They have a telehealth unit within the faculty there. And our current aim of this particular project is to have a look at what opportunities exist, and obviously with that is to also look at the barriers that are there in delivering the telehealth services and how we can overcome that. How economical is it to deliver the services that we deliver? And also what is the impact that it has on the whole of service and the organisation, that being RFDS. So one of the separate studies that we'll do probably later on is to look at the health economics of it. So for example, with the introduction of telehealth services and getting involved in healthcare at an earlier phase, does that decrease the number of retrievals that are then required, for a particular population or a particular illness within that particular demographic. So the methodology, we had to choose the sites based on the internet capabilities. So we're currently going through a phase of changing that, where some of them will be satellite internet. So to give you an example, in a lot of the communities there's one tower in Yunta, which is about 2 hours out of Broken Hill heading west, has one tower. So if everyone in the community is trying to access the internet via that one tower, being able to do telehealth services becomes incredibly difficult. Telehealth is not there to distract from the services that are already there. So it's not aimed at taking away fly-in, fly-out services, but aimed to add value to what's already there. So for example, if you see the doctor twice a week, or their availability is twice a week in a said community, then having a telehealth services obviously increases access to that particular doctor, but doesn't distract from what's already currently in place. So our initial planning for this is that we had appointments on Monday and Wednesday afternoons of half an hour each, where people would ring up, and we used multiple different platforms in order to do that. So one of the components of this was to look at what platforms were more usable, from the clinician point of view, but also from the patient's experience. So this involved using things like Skype, there was Blue Jeans, Vigio, and also some of the actual telehealth devices that I'll talk about later have inbuilt platforms which can enable us to use that. So as I mentioned, There are a couple of devices that we're currently using. One of them is called an inline device, and I think the chaps at the moment have a booth here, and I think our next speaker, he's actually probably going to, he's got it on the floor there, so he may or may not use it. But that particular unit enables us to save patient data into it. So if I see a patient on Wednesday and then they have a telehealth consult in a couple of days' time, then the next clinician can actually see their clinical data that's placed in there. So it has a memory of about 1 terabyte. Quite useful for primary healthcare settings, and one of the things that we're looking at the moment is for the communities where there is no or very limited after-hours care, particularly those where it is predominantly nurse-led clinics or health facilities, of actually having something mounted that is secure, where patients can access the telehealth devices and then being able to link up with a GP. So that's currently one of the initiatives that we're currently looking at. The other one, as you can see, is Doctor in a Box, which was initially designed and implemented by the US military. It comes in a bomb-proof box, runs off a satellite, but has particularly good uses for us in a retrieval context in terms of its mobility, but has the similar features as what the inline service currently does. So what do we know already? So how, in other words, how are we adding? What are we adding to what's already there? There's been a lot of research done around the use of telehealth for specialist services, particularly in the ED setting, and certainly in a lot of the facilities within Far West New South Wales Health District. You know, there are mounted cameras on the ceiling that enable the clinician in location A to be able to access that. But there's very little to be seen in terms of the data that exists for primary healthcare. The patient feedback thus far has been quite positive, and I'll give you some stories later on. And if anything, in terms of some of the negatives around it, has been more around, you know, their first exposure to using telehealth, and it's, you know, just being a different way of particularly doing business. The literature certainly talks a lot about recruitment and retention. So in terms of adding job changes and also job variability that currently exists. So if you look at, you know, the positions within the RFDS, and this is probably a somewhat shameless recruitment drive aspect of it, is very much looking at that. There's the retrieval component, there is the remote clinics that are offered, there is the Clive Bishop Medical Centre, which is the clinic in town, and now we can add telehealth to that as well. So in terms of, from a clinician point of view, there's a multitude of different experiences and also options that we can offer, but also for the patient as well. As I mentioned, one of the other components, one of the other components of this is looking at how telehealth can dovetail into our current service agreement. So how can we add value to what we're already doing that is of benefit to the patient? And as I've mentioned, we're using a number of different platforms to actually do that. So initially we started offering 2 sessions a week with half-an-hour appointments. It's envisaged that what will happen is that these telehealth appointments will be made through Clive Bishop, which is the medical centre in Broken Hill, as you would as if you were going to ring up and make an appointment to physically see one of the clinicians there. So we've actually got a little icon that when the appointment goes in, this icon comes up so that the clinician that's there is aware that that's a telehealth appointment. So you may need to ring or use one of the other multitude of platforms that we're currently trialling through that particular process. As I said, there's been some logistical issues, mainly around the internet componentry that we're looking at the moment. So one of the, in terms of the patient feedback that we've done so far, so this is a very qualitative heavy type of project. So a lot of people have been able to find that they're able to integrate their healthcare into their everyday life. It hasn't been something else that they have to do. So particularly at the moment, given that a lot of the country is in drought, and for people to take time off their properties, which may take a day or even 2 days out of their work routine to come and see you, it isn't a priority to them because they've got stock to feed, they've got water to check and so forth. But this enables patients to be able to stop for 10, 15 minutes, do a telehealth consult, and then get back to work and get on with life. So as an example of that, I had a patient in Ivanhoe who needed some tests done and needed some referrals and things like that, and she was coming into town about 3 days later. So what enabled us to do was to do all that pre-work, all that paperwork. So when she did come to the consult, it was a very quick consult. We had a plan, and she was able to get what she needed out of the face-to-face consult in a more efficient way, as opposed to her turning up, doing all the paperwork, and then going off, getting the scans, coming back, and then developing a plan. But we were able to make that more efficient, both from a clinician point of view and also from the patient point of view. As you can see, I'm not a particularly good-looking bloke, but one of my patients made it very clear he was sure as hell wasn't going to travel to come and see me, so this was a good option. He could ring and talk to me and didn't have to look at me, but he appreciated what I did for him anyway. So there are some inherent benefits to this. So from a clinician point of view, once again, it enabled better use and better efficiency and efficacy of the appointments that we have. So we're able to, do the telehealth consult initially, being able to come up with a plan for the patient, and then when the patient is seen face-to-face, their appointment is actually used better in terms of their particular in particular for their outcomes that they need at that particular point. And as I said, it also enables that dovetailing into what's already offered and augmenting what is already there in terms of the face-to-face component, and adds another dimension to the work that we're trying to do. So moving forwards, we're looking at creating an S3 position. So at the moment there's S1, which is your day retrieval doctor from 7 to 7, and then S2, which is from 7 p.m. to 7 a.m. the following morning. One of the issues is that if you're out flying, so you're out doing a retrieval or whatever the case may be, then the phone calls to the S1 or S2 doctor, but particularly the S1 doctor, then back up. So you may get back from doing a 4 or 5 hour retrieval job and there's 10 phone calls to answer. And some of these may be, can I please get a refill of my Lipitor script because it's Christmas and I've overdone it on cake? Can I need to discuss my test results, I need a referral, whatever the case may be. So as a way of acting as a bit of a gatekeeper, if you like, is creating this S3 position. So the S3 position will be able to take on a lot of those primary healthcare based jobs that come through to take pressure off the S1. So when they get back, they don't have 10 phone calls that they need to answer with. And once again, better use of their time. And also adding to the recruitment and retention strategy and workforce diversibility that is currently already there. So it's envisaged that S3 position, one doctor will be allocated to that, one in the morning and one in the afternoon to help facilitate that process. So that's currently in the pipeline as to how we're going to do that. There certainly needs to be some more quantitative research done on it, as I mentioned earlier, particularly around health economics. Shannon Knott, who obviously is the chair for this meeting, him and I, we're also discussing, looking at around the cultural implications of running telehealth services. For example, is it in terms of how it is done, are there any cultural aspects to it? Do we need to change what we do? How well is it actually going to work for the population that we're trying to service? I think that's one of the values, particularly in relation to the steering group that exists for this particular project, that is that there's a number of people who have quite a number of or vast experience in this particular area, who can guide and help shape that as we go forward. So we've still got a bit of work to do. We've certainly made a fair amount of headway. There's a report that is due at the end of the year that will then look at what services we provide where and what is most efficient and effective in how we deliver those services, and particularly to the population in which we deliver them as well. So we've still got a little bit of work to do, but I think we've made quite good ground thus far. Thank you.
Thanks, Justin, and remember that we'll have opportunities to ask questions to all the speakers at the end. I think Justin's presentation really shows that part of what telehealth can offer is choice, and choice for patients across Australia, particularly when previously there's been little choice. You have to go and travel to see your doctor. You have to travel and go and see a physio. I think one of the big benefits from a patient experience perspective with this is that we are starting to provide people the choice of how they would like to interact with the health system. One of the things that we always talk about is patient-centred care, and one of the things that telehealth is able to deliver for all of us is actually that truly patient-centred care in terms of allowing people to access healthcare in the way that they see fit. I always equate it to the banking sector. I personally would prefer to be able to do my banking digitally, whereas my parents and my grandparents probably prefer to go to the bank. We need to think about providing those opportunities for patients going forward. Our next speaker, Marianne St. Clair, is a research fellow with Charles Darwin University and has been doing quite a significant amount of work in the telehealth space, particularly looking at engagement with and providing access to health services in Indigenous communities across the top end particularly. And I would like to welcome her to the stage to talk a little bit more about her experiences.
Good morning. That's our team. We actually have three of us here. John Kelly is our GP physician who is based in Sydney. David Murtagh is our resident geek. He's sitting there. So if we've got questions that I can't answer, they will help me. I'd like to acknowledge the Larrakia people. These are the local people, lovely people, and those of you that went to the Telehealth conference would have met Ali Mills. She's an amazing lady. Yes, beautiful people. So we have quite a team, which does include 3 Indigenous people, including 2 local traditional owners. So I'm representing the team. We have been working in the Lenape Homelands on a telehealth project. We initially got a seeding grant from CDU. Then the Department of Infrastructure gave us significant funds for setting up a project in 3 very, very remote community homelands. And Telstra Health put some funds in, and there are other partners there as well. Bit about the NT context. 32% of our population are Indigenous, and that's growing. About 80% of them live in remote Aboriginal communities. We've got more than 100 remote clinics, and many of them have very poor access to internet. And until very recently, a lot of them didn't have any internet, and the 3 clinics that we are working with had no internet until recently. There's lots of challenges working in the area that we work in. It's very remote. The telecommunications are unreliable until we put internet into these communities. They just had a landline, and that was unreliable. And we were out at Ilford the other week, and it wasn't working. It's still not working. So you just can't rely on the phones. Very unclean power and unreliable power. The power was out at one of the communities yesterday. Very dusty, high humidity, high temperature. Clinic staff turnover. These clinics aren't manned all the time. They have 1 or 2 or 3 health workers in the community, but they may be away on escort duty or holidays or whatever. And so these clinics are visited maybe once a week or once a fortnight by a GP, registrar, or rural nurses. Logistics are a total nightmare. And there are unexpected events. This is the snake that chased David one day when we were out there. And we were out a couple of weeks doing some installations, and we didn't finish that installation because one of the local people were taken by a crocodile. So that was not nice. And this is where we're working in. Nhulunbuy is about halfway between Darwin and Cairns, and the area that we're working in are a couple of 100 kilometres down below that, so it is very, very remote. This is a good road, but the other roads are very varied. We actually took our Jeep out last time, and the Jeep's very pretty, but some of the pretty things fell off of it. So these Aboriginal people were coming up all the time to see if we were okay, because they all knew about the Jeep. A lot of wet, we all know about our wet. We have cyclones. In the wet season, you just have to take a plane out. You can't get out there any other way. But it is beautiful country, beautiful sea country, amazing people, just wonderful place to work. This is one of the communities by air. And David did learn a lesson: don't park the plane in a puddle, because you have to push it out to get up off the ground. That's our Jeep with all the tech equipment in, and it was stacked just about. Well, in the back was to the roof, and I had a whole pile of stuff on my front seat as well. This is taking those 2 big satellite dishes out, because we needed to get them out to the sites. This is what the clinic looks like. They have 3 clinic rooms. The one on the left is a dental room, and there's 2 clinic rooms on the right with some toilet facilities and office space. We put in 3 big mining grade satellites and provided unlimited, good, reliable internet for them to implement telehealth. And it's gone really, really well. This is a Telstra system with the camera, the screen and little control pad down on the left, and the box with all the IT stuff up on the top there. This worked. It was really good, particularly for specialist clinics. However, it's a bit clunky. These people might be Certificate 2 level out there, so they're not great with IT, and there were issues with upgrades and all sorts of things. So it was a bit clunky for this particular environment. These communities have about 100 people in. Some of the communities we work with only have 30 people in. So, you know, there was a lot of testing and fiddling and trying to get things to work, and you get it working, and then someone comes along next week and unplugs something and plugs it in the wrong place, and it doesn't work at all. So what has happened is they're very creative people. They created their own solution and started using FaceTime. So a lot of the consults that John does is by FaceTime. In this instance, I was actually over with John in Sydney on this day. A spear injury came in on a Friday afternoon. Yeah, John's with us by FaceTime. And John was trying to work out whether he needed to send this person into Nhulunbuy for treatment to the hospital, or whether they could treat him on site. So using telehealth with FaceTime, he was able to make a comfortable decision to treat that person on community and not send them into town. And these people often don't want to leave their community. They're very happy people, very low suicide rates, and in some cases, for example, if their kidneys fail, some of them make the decision not to go to town and die. So we really need to try and provide services to these people. This is John sort of working through. A lot of this stuff is simulated because we don't want to use real Aboriginal people. That other hand was mine actually, but you know, John uses a lot of YouTubes and stuff from the internet to demonstrate things to people. Now, Aboriginal people practice group decision making. So there was a case where a person had a very serious malignancy that needed attention very, very quickly, and the decision to have that operation needed to be a group decision. Some of the family want another community. So by setting up telehealth and working through with John and the clinic staff on site, the person made the decision to have the operation and has had a good outcome with a much better prognosis. This is another community. These are actually a couple of NBN guys. We tested NBN 12 months ago for telehealth, wouldn't cut it. So we really had to go for the mining grade satellite. We are now working with NBN to develop a solution that can provide telehealth. So NBN sent Rocco, the highest level satellite person that they have, out with us, and Tim's the other guy here is the NTSA state manager. And NBN put their money where their mouth was. They actually paid for all those charter flights, and we took these guys around and showed them what the problems were, why it wasn't working, and we're now working proactively with them to address these issues. So this is some of the clinical stuff that John wanted us to talk about. He can actually do stuff real time by using tools. The clinic staff will take videos or photos, send them through to him. He's able to make a diagnosis based on them, develop a plan for that patient. It involves the family so that everyone knows what's going on. It's a much better outcome. And then after the session, John can then actually provide, can we go back? Anyway, okay, thank you. He can actually provide professional development for the staff out there, so they're learning as well. So it's a much, much better way of delivering services for these very remote people. And what John has said is that our staff are hotshots at EARS because they've learned so much from him with this practical training. Some eye issues have been dealt with. That's 10 minutes? Yeah. Some eye issues have been dealt with very effectively using telehealth. John was able to demonstrate how to massage the eye to the patient and the family and the staff on site, and that was a good outcome. Diabetic foot ulcers are nasty things and can result in very serious consequences if not treated properly. John was able to do a assessment on the phone, get the specialist foot clinic, high-risk foot clinic on the line in the same consult, and they all talked through, developed a plan for the patient and arranged for the patient to go into Darwin in the next couple of days. On diabetic stuff, we have a really great hyperbaric unit up here in Darwin, if you ever get a chance to look at it. David has done some time in there with a diving issue, so it's great. He's also done a whole pile of other things. He can do a physician level, John is a GP, but he's also a physician. So he can do a physician level exam by getting the staff in the clinic to poke and prod, monitor the patient's behaviour, and he can actually do a physician's examination with this. And this can have very, very good real-time results. So there's plenty of examples there. So this has really ended up with good outcomes for the patient, good for the family. Off-site clinicians can talk to the patient and family, and we actually have some anecdotal evidence which we'll look into further next year, that the specialist consults via telehealth where the regular GP, the clinic staff and the family there are more effective than a face-to-face specialist visit. So it's great for staff morale. They don't actually have much turnover of staff, they're pretty good. Staff are empowered, the patients are empowered, and it's much, much more efficient and better and reliable decision making. Now we're also tied up with a mob called the Broadband for the Bush, and ACRIM is involved with Broadband for the Bush. We're doing a survey on their behalf, so the link is there. We'd really be great if people can participate. We're also doing some case studies. ACAN supported this funding. There are actually 28 questions in the survey, 10 are specific to telehealth, and the results, the eHealth team at ACRIM will have the results as they come out, so contact them. The initial analysis, we've got a little bit of extra NT people because Broadband for the Bush started in NT, and I guess we're pretty active in the NT, but otherwise we've followed the typical population spread. We are finding some initial results. We have demonstrated that you can do telehealth by satellite. We didn't know for sure whether we could due to delays, etc. We can do it. We're now going to look at using NBN for regional, rural and remote people, the RRR. We've got the most remote cattle station in Australia wanting to trial telehealth with us. Some responses about the telehealth components. When I presented at a seafood conference about 3 years ago, about 100 people, only 2 people in the audience knew what telehealth was. The survey shows that 75% of respondents now know what telehealth is. Not many people are using it, but more than what would have been a couple of years ago. They're saying that telehealth should be made available to them and that GP consults by telehealth should be billable. So our future research, this is the starting list and it's probably going to get more and more. Our first order of business is to see if we can do telehealth via NBN satellite, which is much, much more affordable than the high-grade mining satellite. If we continue that contract, it was going to cost us about $90,000 for 3 communities for 12 months for their internet. So NBN is going to be much more affordable. We're also looking at diagnostic tools that are simple and easy to use and affordable. These community clinics don't have big budgets. They need simple, safe, reliable and robust systems for telehealth. There's a stack of references there. And that's us if you want to contact us. We both work at the Northern Institute. We're now the College of Indigenous Futures, Arts and Society. So if you have any questions or comments, please let us know.
As I get the speakers to come up and take a seat, I think one of the great things with your project there is really showing how you can think out of the box in regards to how telehealth is delivered. I think, again, if you were to listen to some people who would say telehealth doesn't work or it's not effective, they would argue that it's because you can't touch the patient, you can't examine the patient. But through working collaboratively with people on the ground, it's clear that you can, and I've certainly experienced that. I work in one of my previous roles in Western New South Wales Local Health District in a unit where we would provide advice to multiple clinics across a large area, and we'd often get nurses to be able to do our examinations for us, and Randall Greenberg here still works in that unit. And you are able to see, so if somebody's got an acute abdomen, do they have rebound tenderness? You can watch them on camera, and even if the nurse doesn't necessarily know how to do the examination, you can talk them through it. I've talked through nurses to be able to look at peripheral ear, peripheral causes of vertigo as well. So you can make a difference. So I think that was a really good example of that. I might kick off to the panel in terms of the first question before we go to the floor. In your experience, you've all sort of had varying experiences with setting up telehealth in very different, diverse communities. What would be some of your key sort of lessons learned in setting up a telehealth project in rural or remote parts of Australia?
I guess consultation with the end users and the clinic staff is really key, and that's what we started out doing, was just going out there talking to people. And the next thing I think is just keeping it really simple and robust. We've found the systems deployed are too complex, too unreliable. It needs to be simple, reliable, robust.
I would say keeping in mind that you're not only trying to do telehealth, but try and manage it, which means think of all the users, whether it be it patients or doctors. We want to make it as hands-off as possible. You don't want a doctor trying to fiddle without, or a patient who is in a lot of pain trying to figure out how to do use FaceTime or anything like that. And I think the key thing is just make sure you have enough support structure there so that it is very hands-off and simple.
Certainly that collaboration between patients and also clinic staff, as well as previously it has been mentioned, is probably the key to that. And looking at how it can be integrated almost into everyday care and scenarios. And certainly one of them has been able to organise having a three-way conversations where you can get the specialist to link in at that particular time, or a more senior clinician being able to link in as well, certainly adds to the patient outcome in the end.
Is there any questions from the audience for the panel? Just here.
Just a question for Marianne. Very, very exciting project. Just wanted to ask in terms of the funding for the initial setup, so for the infrastructure, the satellite dishes, and the initial telehealth setup. What was the funding structure for that? And also, if possible, for the ongoing consultations as well?
Before you begin, I'll just reiterate the question because some of the people at the back might not have heard. The question was just around the funding structures for setting up the telehealth project that Marianne was talking about.
a big chunk of the money was for the satellite and connect. We paid for 12 months connectivity. Now, if you use NBN, they pay for the satellite, so you're only paying your monthly service. The total project budget was probably in the order of around 600,000 when you include CDU's, AMSANT's and Telstra's contribution. However, we think now that we can probably set up a clinic probably for around 15,000 with a monthly bill of maybe a couple of $100 a month for internet. So that would be about right, I think. That's what our next project actually is, to work that out. So next year we'll be able to tell you all about that.
There's a question. Richard.
Thanks. I'm not a clinician, but I'm very interested in the work that I do in relation to access to services in communities, particularly rural and remote communities. And one of the things that I've seen over the last 5 or 6 years has been an increasing interest in the conversation about how to go about telehealth. But I'm very interested to be in this room today and knowing there's over 600 delegates here at this conference, and to see, I've counted 45 in the room, and I'm not a clinician, so I'm not sure how any others aren't clinicians either in the room. But I'm very interested in your take, probably as true believers in the telehealth and its potential. What comes next? Where are we going to be in 3 or 4 years? I noticed when I turned up to Darwin 2 days ago that the Success and Foes of Telehealth conference was on 2 days prior to this conference, and so that conference is happening, and then we're here now. So I guess my question really is, where are we going? Where are we going to be in 3 years' time? And as true believers and obviously experienced people in this work, what are we going to see in the future?
From my perspective, I have this vision that anyone from the community can walk into the clinic, and the clinics aren't necessarily always locked, and initiate a telehealth consult. And we actually had that happen. There was an MVA, there were a number of people injured, and one of the community members was able to instigate, with help from John on the phone, to triage and organise everything. In the long term, if any of you have been to the Health Informatics Society conference, you'll see some of the stuff that's been happening there. I don't think we're very far away from having some of those technologies, you know, where someone walks through a clinic and the hologram pops up and please state the nature of the emergency. I think we're getting there.
Look, it's certainly, you know, from my perspective, it'll be integrated into what is currently defined as healthcare, and it'll be another modality at which people, or patients in particular, will be able to access a clinician. I think some of the issues probably, you know, sit around the encryption of data in particular, and how we maintain confidentiality and security, particularly in that sphere. And then also looking at stuff around quality assurance and more the health systems as opposed to the actual implementation of the technology. As Marianne's mentioned, it's certainly a long way down the track in terms of its implementation, but then the other, you know, support components then catching up to it.
And I share the same view as Justin and Marianne as well, in the sense that I think telehealth has been happening since a long time. But I think we're at an inflection point now where all the right technologies, all the right infrastructure with NBN, all the right, I guess, the psychology around the need for it, I think it's all reaching one critical point now where I think within the next 3 years, hopefully we'll see more development in 3 years than we have seen in the last decade. So it's very exciting and very promising for communities out there.
Question just at the front here.
Workflow impact, and as a GP, setting up a teleconference with a patient, it is wonderful to be able to sit in on them, but it absolutely blows the rest of my appointments out of the water, and then the Medicare billable or non-billable aspect of it. And I think there's a lot of us probably in that position who would love to use it more for our patients' benefit, but it comes at quite a cost. And I know that sounds a very egocentric sort of position for me to adopt, or a selfish position, but it's a reality in my workday in the rural context.
My understanding, there's certainly been some discussions with Medicare around the billing components of it, and that's certainly one of the main barriers is how do we, able to bill for that given the outlay of costs. I mean, it's got to be economically viable for you to actually offer those services in the first place. In terms of the appointment and the workflow components, we'd put in half an hour appointments, and one of the part of that of the trial is to then look at what platforms are more useful or easier to use. So, for example, not having a particular bias to any of them, but Blue Jeans, for example, I can send the patient an email, they click on the link, hey presto, it's there and it joins up, as opposed to some of the others where they have to create an account and then log in and so forth, and it just adds another barrier to them being able to do it. But I think that's certainly one aspect that's been heavily examined is around workflow and how can it be integrated into your daily clinic routine without actually messing up the daily clinic routine at the same time.
I'll just add quickly to that. I think one of the things that we need to look at is how do our workflows work with telehealth. The same way that with the advent of GP management plans have come into practices where a GP is involved for a part of it, and primarily it's the practice nurse that does a lot of the work, and there's obviously different workflows depending on individual practices, but there are ways around to avoid the, I suppose, sitting there for an entire consult, which blows out your day. The funding component is a really interesting one, and one that I think organisations like Akron RDAA, the state RDAs as well, really need to have a strong voice around, because the benefit that, according to the way that things are remunerated in telehealth, is that there's benefit for specialist care. When we know that all studies across healthcare, the best bang for your buck, including in telehealth, is in actually primary care settings. So we need to be able to advocate for that. So we need to have a common voice saying that this is the way that we want to go and this is the way that our patients will like to access. But there are also additional opportunities coming forward now, I think, with the advent of, certainly in New South Wales, trialling things like integrated care. How can we build an integrated care package for patients with funding from local health districts or the states that come into primary care as well, where that funding bucket is not necessarily constricted by our own billables from an MBS perspective. Up there.
My name's Ted Chamberlain. I'm from Queensland, and I have, two bits of credential. One, in 1991, in the first Rural Health Alliance conference in Toowoomba, I gave a presentation on telehealth, and I pointed out that there was an inflection point in the technology, and we're about to take off. The second point is I run one of the largest movement disorder clinics in Queensland out of a small rural hospital, and we do 10 to 20% of our consultations by telehealth. Now, my experience is that it's not technology, it's culture. So how do you change people's culture, especially doctors' cultures, to use this?
Well, thanks for your question there, and thanks for pointing out that your predictions back then. Look, I do share very similar views with yourself as well. The hardest thing is, and if I go back on anecdotal evidence on managing all these telehealth sessions that consultations that we've done for communities around Australia so far, is, it all comes down to fear. Sometimes, having to move from Skype to FaceTime or something is a huge change, and it all comes down to the conversations, the type of conversations that we have with the support staff at the practice, to GPs and specialists. And I have to admit, sometimes a consultation has to be completely cancelled because they just won't move away from Skype, for example. So, I think technology should continue to make it a lot easier and facilitate telehealth. The biggest change, and I think what we've found working with so many GPs and so many specialists and patients, is it all comes down to the psychology of it. Embrace it, give it a shot. I think at the other conference you mentioned there was a success and failures in telehealth conference just before this, and they did mention that there was a little joke that was thrown around, and that there's been more pilots in telehealth than there are pilots at Qantas. So I think it really is time to just embrace it, give it a shot. There's no, it doesn't hurt to fail, and I think that's the way we need to proceed with our sort of thinking moving forward as practitioners and community service workers here.
Look, and it's certainly building up that rapport with the patient or the specialist, and being able to follow that through, like in terms of a patient journey experience, of then helping them demystify, telehealth and where it sits in that modality of healthcare.
I'm getting the wrap up now, guys, so I know there's quite a few questions in the audience still to come, so feel free to come and approach our panellists